Hello, everybody. This is Dr. Marzban from CIC. We're going to be talking about muscle stress reflex from the eyes of a clinician. Besides having the information that will be a review for most of us, there will be some information, hopefully, that you will benefit from it in your practice as far as the results goes. Either they are negative or positive, they are strong or weak or normal. And we'll discuss that, what they mean to us, and how the mechanism of the muscle stress reflex is. Hopefully you will enjoy it. Muscle stress reflex can be done on multiple areas of the body, and the common places are patellar reflex, Achilles reflex, biceps, triceps. And a reflex basically is a combination of sensory input which affects on motor output. And it is also needed to be emphasized that the amount of force that you put on a sensory, it will have a motor output in reaction to that sensory, which means that more sensory comes in, the greater motor output will be. In order to be uniform, doctors will use the reflex hammer in this case, and this one has a weight which is consistent all the time. And the force that you perform, it is just releasing this hammer on the tendon, and the distance that you use that comes down and holding it, it is going to be a uniform type of force. And you would like to be consistent because you're going to be comparing right and left side, and to see that if one is weaker than the other side, and again, you will go with the side of the disorder to be the abnormal response. And so the edge of the hand, sometimes the doctors use it. I've seen it in the hospital, and the doctor used the edge of the hammer to see that the reflex is present or not. But on this picture, you see that we have two pictures. Both of those are showing that the knees are flexed. We're going to see that why we would like to keep the knee flexed as such to get the response. And the force that the doctor put on the tendon, it is very important, as we said, that the force, which is the sensory that is coming in, it is giving the motor output. So the force should be consistent, which is the mass. In this case, is the weight that you put from the reflex hammer or the hand, and the acceleration and the speed that you put it on the tendon. And it is very important as far as the speed goes, because the speed should be fast in order to get the response, because the sensory receptors that we have in the muscle will respond to a faster speed force, which we'll discuss that momentarily. Muscle reflex can be done on multiple areas of the body, and the common places are patellar reflex, Achilles reflex, biceps, triceps. And a reflex basically is a combination of sensory input which affects on motor output. And it is also needed to be emphasized that the amount of force that you put on a sensory, it will have a motor output in reaction to that sensory, which means that more sensory comes in, the greater motor output will be. In order to be uniform, doctors will use the reflex hammer in this case, and this one has a weight which is consistent all the time. And the force that you perform, it is just releasing this hammer on the tendon, and the distance that you use that comes down and holding it, it is going to be a uniform type of force. And you would like to be consistent because you're going to be comparing right and left side, and to see that if one is weaker than the other side, and again, you will go with the side of the disorder to be the abnormal response. And so the edge of the hand, sometimes the doctors use it. I've seen it in the hospital, and the doctor use the edge of the hammer to see that the reflex is present or not. But on this picture, you see that we have two pictures. Both of those are showing that the knees are flexed. We're going to see that why we would like to keep the knee flexed as such to get the response. And the force that the doctor put on the tendon, it is very important, as we said, that the force, which is the sensor that is coming in, it is giving the motor output. So the force should be consistent, which is the mass. In this case, is the weight that you put from the reflex hammer or the hand, and the acceleration and the speed that you put it on the tendon. And it is very important as far as the speed goes, because the speed should be fast in order to get the response, because the sensory receptors that we have in the muscle will respond to a faster speed force, which we'll discuss that momentarily. This slide shows the muscle stretch reflex mechanism that is done on the quadriceps at the spinal segment. And here is the hammer that doctor uses, and you put that stimulation, and here is the force that you put on the tendon. And the reason that is done is because you would like to stretch this muscle. Greater force, greater stretch. And again, the speed is very important, that you would like to give that fast so the muscle can respond fast. And the reason for the fast force is because there are receptors within this muscle, which are called the muscle spindles. They are responding to the fast stretch. So when the muscle is stretched, like quadriceps in this case, the muscle spindles, which are receptors within this muscle, will stretch with it. The faster it is being stretched, the greater impulse comes in. Again, we're going to see that the reflexes that you have on different patients are not going to be the same. So every individual has its own reflex response. So comparing the different people are not really a good way to deal with the diagnosis and results. So you always want to compare right and left side to make sure that the normal side and the abnormal side, what they show to us. So you always compare with the normal side. Here's a sensor comes in, and the conduction comes to the central nervous system. Within the central nervous system, it does multiple different things. Sometimes it goes directly to the motor output. Sometimes it goes indirectly to the motor output. So the information comes back to this biceps from the sensory that it gives that information. So they're all coming from the same muscle. So sensor comes from the quadriceps, and the motor comes back to the quadriceps. So we call the quadriceps to be agonistic muscle. So the information comes to the spinal cord, not only goes to the agonistic muscle, the information also going to be shared to the antagonistic muscle. And in this case, the antagonistic muscle is the hamstring. This picture shows that the information that comes to the agonistic muscle motor output, which is called the alpha motor neuron, it is monosynaptic type of communication. There is no interneurons is involved with this case. The information that comes in from the muscle spindle that goes indirectly to alpha motor neuron, it is via the interneuron inhibitory, and the inhibitory will cause the inhibition. It is also important to mention on this slide that all sensory inputs comes in, It doesn't matter where it's coming from the muscle spindles or from the taste, from the vision, from the hearing. The sensory input's always going to be stimulatory. So if you see any inhibition happening, it should be done by some type of interneurons. When the information comes in, not only the information is being shared on one side of the spinal cord, it will be shared by the other side of the spinal cord. At the same time, it will travel up and down, and if it goes up, it will go to the higher center. Here we have monosynaptic right here, we have polysynaptic right here. Polysynaptic requires interneurons, and the interneurons, they could be either inhibitory, but not all interneurons are inhibitory neurons. And the stimulatory neurons and the inhibitory neurons, they work together. And the important thing is the net effect at the end. What would be on the postsynaptic neurons? And in this case, there would be the alpha motor neuron. All right, and this is the slide that we talk about, and let's see what we can add to it. Is that here is the quadriceps as we talk about, and within the quadriceps we have muscle spindles. The muscle spindles that we are interested in is the nuclear bag because it's the one that responds to the fastest stretch. And so the nickel bag, when it's stretched, it gives the signals through the action potential. Those are the signs right here, positive signs as action potential. And the action potential is going to travel along the axon. Since it's coming from the nickel bag, it is carrying the information by the 1A type of fibers, which are very fast. And the information goes very fast, travel along the nerve, which is the femoral nerve, and it is going to the L4 nerve root. And through the L4 nerve root, it goes to the L4 spinal segment and through the dorsal horn. And it gives the information to multiple areas as we discussed that before. And here's the monosynaptic input, here's the polysynaptic input, and then the information goes to the alpha motor neurons, and the alpha motor neurons to the agonistic muscle, in this case, become hyper stimulated, and the information that goes to the antagonistic alpha motor neuron becomes hypo stimulated, and the both of those are still sending information to the muscles, but the information goes to the muscle. It become less, and the information that goes to the quadriceps, it becomes greater, and the greater muscle stimulation and contraction in the quadriceps, it will overcome the contraction which is mild in the hamstring because every muscle has some type of contraction all the time. And so the greater stimulation on the muscle quadriceps will give that kicking response, which is extension of the knee. And more stimulated sensory fibers, more stimulated alpha motor neuron to the agonistic, and lesser stimulation of the alpha motor neuron to the antagonistic muscle. So if you have 3 positive, you will have 3 positive here and 1 positive on the alpha motor neuron to the antagonistic, but 3 positive to the alpha motor neuron to the agonistic muscle. So there is the correlation between the effect that the motor response coming to the skeletal muscles based on the level of the information that comes from the sensory to the central nervous system. This slide shows that we have muscle stretch reflex, and the other name for muscle stretch reflex is the spinal proprioceptive reflex because it's dealing with the proprioception, and the proprioception is referring to the knowing where we are and how we move in space. And the stretch reflex, in this case, which is done by the nuclear bag, is the type of proprioception. And so either name can be used for that. But previously, the Golgi tendon reflex was the name used for the muscle stress reflex. So that is doesn't make any sense, and therefore it is getting out of the textbooks. They don't refer to the muscle stress reflex, Golgi tendon reflex anymore. And Golgi tendon reflex is its own reflex, which we're going to talk about that in a second. But again, the knee-jerk reflex or the patellar reflex was a type of reflex that involved the L4 nerve root and femoral nerve. And any reflex that we have, it has association with the nerve root and a nerve or nerves. And so here is the knee-jerk reflex. Here is the L4 with the femoral nerve. Achilles reflex is the S1 nerve root and tibial branch of sciatic nerve. Biceps reflex is the C5 nerve root with the musculocutaneous nerve, and triceps is C7. Brachioradialis is C6, but both of those are dealing with the radial nerve. So, with the reflex examination or muscle stress reflex, you are able to test the sensory motor nerve and root, and then these are at the segmental level. Then you can expand your the diagnosis and to the higher center of the brain stem, cerebellum, cortex, basal nuclei, and so forth and so on. This slide shows the comparison between the muscle stretch reflex and the Golgi tendon reflex. And the muscle stress reflex, as we talked about that previously, is that when you stretch the muscle fast enough to excite the muscle spindle, then the muscle spindle excites the corresponding the nerve, and in that case would be the femoral nerve. And as it approaches to the spinal cord, it is the L4 nerve root. It goes to the L4 spinal cord segment through the monosynaptic or polysynaptic communications. It would give the information to alpha motor neurons, and the one that goes to the agonistic muscle becomes excited. The one that becomes part of the motor neuron to the antagonistic muscle becomes less excited or inhibited in that case by this picture. Inhibition, as we talked about, is always by interneurons. If you look at the Golgi tendon reflex, the Golgi tendon reflex is also a stress reflex, and this organ is located within the collagen fiber of the tendon, and they're also responding to a stretch when the muscle is contracted in that case, and the amount of the contraction, the Golgi tendon organ become more sensitive. It reaches to the point that it can excite the sensory neuron. In that case, is 1B fiber, and the 1B and 1A are the same speed, but they are being called A and B to recognize what type of reflex and nerve we are dealing with. And the sensory information goes through again femoral nerve and goes through the L4. It enters the spinal cord segment, and when it does, through the polysynaptic communication, now no monosynaptic but polysynaptic communication. Now it talks to the agonistic and antagonistic alpha motor neurons, and you notice that the interneurons that are located right here, as the is not only one. Don't make that mistake. There are many interneurons are involved with that type of reflexes. More interneurons are involved, it brings more delay to the response, as you can notice and realize that because there's going to be extent of the communication between neurons, and each communication takes some time and delay the response. And so the polysynaptic always going to be longer and more delay response than the monosynaptic it is. And here's the polysynaptic response, and the polysynaptic response that the alpha motor neurons will receive. It is the collectively information that coming from all the interneurons that is called summation, and this summation is the net effect of the interneurons at the ventral horn, and you notice that this summation end result on the agonistic alpha motor neuron is inhibition, and the effect on the alpha motor neuron to the antagonistic muscle is the stimulation. So the signal right here, the reverse. So here is the positive on the agonistic alpha motor neuron. Now it becomes negative on the agonistic neuron. And so the neurons which are carrying the information to the muscles is the same neuron that carry the information through the stretch reflex. And the consequence of the all response that these alpha motor neurons will bring back to the muscles is that it causes excitation of the hamstring and the relaxation of the quadriceps, and therefore it would bring some kind of flexion to the knee as a result of the reflex. But that flexion usually you don't see that this become exaggerated, but it is giving that inhibition to the antagonistic and stimulation to the agonistic muscle for the purpose of gait and balance, which we will talk about at a later time. This slide shows that we have biceps, one with flexed elbow and the other one with less flexed elbow. And it is showing that we are putting force FA on both sides, and so the force is the same with the reflex hammer, but the muscle is having different length size, and because of that, the response is going to be different. So when you put a force on a muscle that is already stretched, where the muscle spindles is stretched as well, the muscle spindle will respond at the great amount. When the muscle is shortened and uh, and and then you put the force on the tendon, and the shorten means that when you flex the elbow passively and the muscle is shortened and relaxed at the same time, you put the same force on the tendon, the effect would be less on the afferent fibers. So here you have the positive, which are again referring to the frequency of action potential per period of time, which is greater, and here is the you have the lesser frequency of action potential along the same afferent fiber, and here the information comes in and through the nerve, and in this case the musculocutaneous nerve. It goes through the nerve root, which is the C5, and the information goes through the nerve root, gets to the dorsal horn, and it will enter the ventral horn. And with the greater frequency, and that brings the more information to the central nervous system, you will have a greater output, and therefore the contraction of the muscle is going to be greater. The lesser frequency of action potential in the green case, the lesser impulse is going to come back to the muscle, and therefore the muscle is not going to have as much as contraction, even the force are the same. And so when doctor is performing the muscle stress reflex, they will like to put some tension on the tendon before hitting the tendon, because that brings the muscle spindles to be more reactive. Again, if the muscle is not showing the response with the reflex hammer, doctors can put the finger on the tendon and pull it down and distally, then hit the tendon. So with the pulling down and distally stretching the muscle, you bring the muscle spindle to become more excited by the reflex hammer to hitting, and therefore you will see the response. But you need to make sure that when you do that, you are also going to be stretching the tendon on the other side as well. So uniformity of the examination between the right and left side is very, very important. And by seeing this one, now you understand that why you put the knee in flexion before you perform the patellar reflex. Here is the patellar reflex again, and if you put the leg in extension and you hit it, you have lesser response that you see. normally. And when you decrease the knee angulation, you stretch the muscle. As you decrease that, you put the stretch on the quadriceps, then the amount of the response will be greater. So when you perform the examination on the patient, you always have to make sure that the knee position is the same between right and left side. Otherwise, you may have a different response, and you will get a different response if the angulations are different, and therefore you may interpret the result differently. Again, this picture shows that the foot is hanging in the air, and the reason is that you don't want to put this foot on the floor or somewhere that the flexion of the knee is prevented. And so it shows that how the extension works. But at the same time, not only you would like to observe the extension of the knee, you also can put the other hand on the muscle that you're testing to feel the contraction of the muscle. Sometimes the response is so minimum that you don't see the reaction by observation, but by palpation on the muscle, you feel the contraction. This slide shows that we have intrafields muscle fiber and intrafields muscle fiber, or the muscle spindles, which are the same. There are two types: nuclear bag, nuclear chain. And this one, it shows we have 1A afferent fibers, and therefore this should be nuclear bag, because nuclear chain information carried to the central nervous system by two afferent fibers, type 2. So if it is 1A, that shows us it's a nuclear bag. Information goes to the central nervous system. The other thing that shows that this should be nuclear bag and 1A afferent, because it is a monosynaptically affecting on the alpha motor neuron right here, which that's the only time that the 1A afferent fibers or the sensory afferent fibers in the spinal cord will have monosynaptic effect on the motor output. So here is the monosynaptic communication right here. But this picture also shows that we have other information coming in from different sources, like the skin, different part of the muscles, the joints, and so the information is going to come in from other sources will have also some type of effect on the motor output and the reflex. So the reflex is not a simple mechanism; it's like a very complex mechanism. When the information gets to the spinal cord, then the spinal cord will share the information to the higher center and lower area, and the higher center can go all the way up to the central nervous system. But along that distance, it will affect the brainstem, cerebellum, and other structures in the central nervous system. And this picture also shows that we have descending fibers that coming down, and these descending fibers will affect on the response that the motor neurons will have to the sensory inputs. And so these descending fibers are very important for the modulation that these alpha motor neurons will have. Otherwise, the reflex will have no regulation, and no regulation will cause the disorders. And all afferent fibers are bringing information, which are the inputs, sensory inputs. They're all excitatory. We talked about that before. So it doesn't matter it is 1A, is 1B, or 2, or any other sensory coming in. All the primary neurons that are coming in to the central nervous system, they bring the positive input. So any type of regulation is going to happen is by interneurons and with the inhibitory system, and also the excitatory system that will come in and play some type of rules in between the neurons. Now we are on this picture right here, and it shows that we have higher center that's sending information down to the spinal cord. They're coming from multiple areas like the cortex, reticular formations, and vestibular system, and naming most of those, and sending information down to the spinal cord. and they travel through the funiculi, and when they reach to the spinal cord at different segments, they give the inputs to the ventral horn, for example, and also it gives the information to the dorsal horn as well to modulate the information that will end up on the alpha motor neurons. So here are the modulator effects by descending tracks. Some of them are positive, some of them are negative, but overall it depends on the type of interneurons they're communicating with, and then the summation, as we talk about, of all the signals coming between the neurons and interneurons will give the final effect on the alpha motor neurons. This slide shows that the mental power on the reflexes, and here is the modulation again, and that is done by the cortex, the role of the motor cortex on the modulation, and the changes of the environment, and even verbal suggestions will have a different effect on the muscle stress reflex, and therefore your reflexes that you're testing on the patient is continuously being regulated, modulated by the central nervous system. But again, the effect that you have at the spinal segment, it is much fast, and that the effect that is coming from the cortex, if it is going to be happening, there's a delay to it, because again we talk about that multi communications, and every communication set it requires time. More communication sets will have a longer delay, and but again, if the patient is thinking about the reflex that the doctor is performing, that input is going on even before the reflex is being done on the patient. This slide shows that we have multiple loops. We have short, medium, and long loops that affects the muscle stretch. And so the short loop is the fastest one that you see in the patient, but the brainstem, cerebellum, basal nuclei, and the cortex, they are continuously regulating subconsciously and consciously by the cortex, and therefore the response will be affected and modulated differently. So based on the prefrontal cortex area, which is your cognition and thought processing part of the cortex, and the motor area and the sensory inputs that coming to the main part of the cortex, they all play some type of effect on the end result that you will have on the patient reflex with the, in this case, the muscle stress reflex. So when you see the results in the muscle stress reflex, you also have to think about not only a spinal cord segment area, but also at the higher center, how the other things are coming to the picture, and if they are participating in the response that the patient is giving. Well, this is the old picture that is done on the patient or the participant. And here's a reflex hammer the doctor is performing, but this is wrong right here. And because the foot is on the floor, an extension of the knee is prevented. So there's no free flow to the foot to have a extension that the patient needs to observe. And again, this shows the Jindresic maneuver. And Jindresic maneuver basically is distraction of the mind. It's like playing chess. And when somebody is playing chess or trying to solve a problem, or performing a different thing, a different part of the body, in this case the upper extremity, you are distracting the mind that has a modulated effect on the reflex. So if the brain is trying to inhibit this reflex mentally, the distraction of the mind to some other things will remove this inhibitory effect, and therefore you can observe the reflex at the greater amount. This slide gives us uh, understanding by drawing of the short, medium, and the long loops. And the short would be a spinal cord, the medium would be more so of the brainstem, the longer loop would be at the cortical level. And but again, let's review some of those as we talked about it before. Here is the muscle spindle within the muscle, and you stretch the muscle right here and fast enough to stimulate the nuclear bag, and nuclear bag carries the information through the 1A fiber, where the nuclear chain carries the information through the two fibers, and then two fibers will come later time after a delay. And not only there's a delay to the alpha motor neuron by the nuclear chain because of the nuclear chain has its own delay response, but also the group 2 is a little bit slower than the group 1, but at the same time, you all have the interneurons, and again, extra communication delays the response. So the two fibers to affect on the alpha motor neuron, it has a graded delay. And so the primary effect that you see by the stretching of the muscle spindle with the muscle stretch reflex, it would be 1A on alpha motor neuron. While the alpha motor neuron, it is having other inputs coming in for the modulatory system. They are uh, being responding differently based on what higher center and segmental area they are talking about. But again, this picture shows that we have gene dressing maneuver, and with the gene dressing maneuver, you are disinhibiting the input you have on the alpha motor neuron, and therefore you will have a better response to the muscle in the muscle stress reflex. Now we're going to be talking about the differences between the upper motor neuron lesion and lower motor neuron lesion. And the lower motor neuron lesion, which is the lesion to the alpha motor neuron, you would expect that if you don't have alpha motor neuron functioning, therefore you don't have a tone, or you have lesser tone, depending on the extent of the damage. So hypotonicity is given, and then the muscles doesn't have that firmness, and therefore they don't have a tone, and therefore it's called the flaccidity. And because the reflex, the muscle stress reflex that we talk about, it requires the sensory as well as the motor, and that causes hyporeflexia if you don't have the alpha motor neuron causing contraction and completing the circuit of the reflex. And again, at the end, the muscle requires alpha motor neuron to fire all the time to preserve its firmness and tonicity. And therefore, if it doesn't receive that alpha motor neuron, it will be wasted. It will become wasted, and the muscle becomes weak, and then it becomes very soft, and the muscle waste is another sign of the lower motor neuron lesion. With the upper motor neuron lesion, in this case, we talk about the corticospinal tract, and is one of the descending tracts. And we know that the cortex causes inhibition to the reflexes and to the tone, to the alpha motor neurons, normally in a resting mode. And therefore, if you don't have that inhibitory effect on the alpha motor neurons, it causes the firmness to the muscle more than what it should be. Spasticity is called. And then you have the hypertonicity because the alpha motor neuron are disinhibited. And you have hyperreflexia there because of the disinhibition on the alpha motor neuron. And therefore, the sensory coming in has the great effect on the alpha motor neuron. and then the muscle will have the greater response to the muscle stress reflex due to the disinhibition. And in the follow-up videos, we will talk about the different types of the upper motor neuron lesions, decerebration, decortication, and hopefully it will clear up some of the confusion, and it gives us a better understanding of how the muscle stress reflex examination results can give us ideas what is wrong with the patient and what needs to be done for the patient. I hope that you enjoy the presentation. You have a wonderful day.